sudden loss of hepatic function in someone who otherwise has normal liver function. And that's defined as a coagulopathy of an INR greater than 1.5 and an encephalopathy. All right, and the incidence for that is about it's about 0.1% of all deaths. It's 2,300 to 2,800 cases per year, and it's responsible for 6% of all liver-related deaths. But this isn't to be confused with chronic liver disease, with cirrhosis. Okay. Chronic liver failure with cirrhosis is much more common than acute liver failure. It's a 12th leading cause of death in the U.S., and it has many complications, as we all know: varicose hemorrhage, ascites, SVP, hepatorenal, hepatopulmonary, etc. All right, so acute liver failure. Like we said earlier, it's the severe dysfunction and damage of the liver sites in an otherwise normal and healthy individual. And it's really the loss of synthetic function and the loss of degradative roles and breaking down of the compounds. And these manifestations, appropriately based on the liver function, you'll see coagulopathy, hypoalbuminemia, and that's the synthetic function, and then you'll see toxins such as ammonia accumulating in the body. In etiology, this can be viral, it can be toxins, it can be something called Budd-Chiari syndrome, tissue disorders, autoimmune. But the important thing to realize about liver failure and acute liver failure is that about 15% of all cases of liver failure, the etiology is actually not determined. And then the pathophysiology for liver failure is going to vary with each cause, and so therefore the treatment is going to vary as well. And chronic liver failure, just to get this out of the way early, this is not synonymous with cirrhosis. Cirrhosis is the pathology unifying chronic liver failure. And what this is you have fibrous and regenerative nodules in the liver. This decreases the blood flow, increasing the portal pressures, essentially leading to splenomegaly, dilation of blood vessels, and then all the complications that come as a result. And here's just a nice kind of pointer. I pointed out, but I think you guys get it, right? All right, so some chronic complications. We'll go over them briefly, and then we'll talk more in detail about some of them later. The first one is ascites. Ascites, when you think about ascites, you're thinking about two factors at play. You're thinking about the hydrostatic pressure and the oncotic pressure. The hydrostatic pressure being the force that pushes against the walls, maybe pushing fluid out, and the oncotic pressure is the proteins in the blood that's going to bring the fluid back in. And when you have ascites, you're really getting a imbalance between the two. You'll end up with elevated pressures causing fluid to come out, maybe not enough pressure bringing them back in, depending on what stage they're in, and eventually you'll get fluid buildup in the abdomen. Another chronic complication of hepatorenal syndrome. This is acute liver failure in the setting of someone with otherwise normal renal function, and now progresses to renal failure. And it's caused by essentially a low effective plasma volume seen by the kidneys, causing vasoconstriction, and also it sees a decreased cardiac output. And so just in terms of, real quick, the International Ascites Club criteria, I really just like the name of that. So the first two, cirrhosis with ascites, that's the liver failure. The creatinine greater than 1.5, that's a new elevation in creatinine. That's the kidney part. And then the next three are really just saying that this is not preload dependent or not due to any intraparenchymal lesion in the kidney or anything like that, parenchymal disease. So you're giving fluids, you're giving volume expansion, that's just so that the kidney sees preload, because maybe this is just AKI for your preload dependent problem. And then the other ones, nephrotoxin, parenchymal kidney disease, that's just saying that the kidneys were otherwise normal. And then you have other chronic complications of hepatopulmonary. This has a wide prevalence, so that's essentially useless, but I figured I'd put it in there. And so what you get is hepatic findings, and you'll get pulmonary findings, such as shortness of breath. But how do you differentiate that between regular just COPD with liver failure and somebody who has hepatopulmonary syndrome? And one of the important things that I found that I briefly mentioned is spider nevi are actually very important for this. People with spider nevi, and this is what a spider nevi is, they have a odds ratio. It was, I think, you can see in the A gradient, it's usually like 20 for them, 8 for someone who doesn't have spider nevi. And so you can see manifestations in terms of their blood gases, and they have an increased odds ratio of having hepatopulmonary. But what really defines hepatopulmonary is platypnea and orthodixia. And what happens is that when you have this increased portal pressure and you get intravascular pulmonary dilations, and you get these new blood vessels that form. And so what happens is the blood pools at the bottom of the lung. So when someone is sitting up, they're actually short of breath. And when they lay down, they feel better because you no longer get the preferential flow to the bases of the lungs. And so what you'll see is a difference in PaO2 when you do the ABG, and that's actually how you make a diagnosis of hepatopulmonary syndrome. Okay, and just oxygen and transplant treatments for hepatopulmonary. And then another chronic complication, variceal hemorrhage. We all know about this, dilated vessels, they bleed. We'll talk about that later. And then hepatic encephalopathy. It can happen in both acute and chronic liver failure. The liver is too damaged to get out toxins, and that eventually will lead to edema and seizures and death. And I'll mention hepatic encephalopathies, the grades later on as well, because it's kind of important when you're defining it, when you're thinking about liver failure. So I'll do it once here, and then once later on to stress it again. So the first stage is you get just small changes in behavior. The second stage you get more disorientation. Maybe some asterisk starts to form. Third stage you're going to get marked confusion, and then the fourth stage you're going to be comatose. And it's important, one, to see the patients and see. It's going to be important to see whether or not they're criteria for any type of medications or transfer or transplant. So let's just go back to the basics for a second. Let's just talk about the history that you can get of your history, and we'll talk about physical. So you can get the timing of symptoms. Is this acute? Is this chronic? Obviously, that'll tell you right off the bat which category you're starting to form in. And then medications such as Tylenol, herbal supplements, mushrooms. I know that was on the in-service, so I figured I'd throw it in for a little bit. I don't know if I'm allowed to talk about that, actually. Travel, sexual history, blood transfusions, autoimmune, chronic liver disease. You should ask questions like, have they ever had an endoscopy? Do they have anorexia, weight loss, just history of SBP, any renal dysfunction? This kind of just helps you prognosticate where they are and where they're going. And then physical exam, you want to see their vital signs, their mental status, what grade of encephalopathy they have, and then acute. In the acute phase, they'll tend to have a tender hepatomegaly. They can get jaundice, encephalopathy, and asteristics. That's also there in chronic as well. But in chronic, you get all the things we mentioned, the ascites, the SBP, and then you start to get pulmonary edema, maybe some spider angiomas. And then the other thing is that all the jaundice, encephalopathy, and asteristics apply as well. And also, when you get chronic liver failure, what also happens is the liver starts to get shrunken. So as you start to get cirrhosis, the liver gets smaller. So very often you actually won't be able to palpate the liver. You'll feel the spleen, but it should be enlarged. So some lab tests that we can order. Lab tests are useful because they'll help us establish injury to the liver. They'll help us see whether it's synthetic function that's affected, whether it's accumulation of toxins. We can help determine the causal agent, and we can do prognosis as well. So just some aminotransferases that are useful. When we talk about AST and ALT, obviously we know AST is more common in other places, such as the heart and the kidney, whereas ALT is less common in other places. So ALT is a little bit more specific for the liver, but both of them can be mildly elevated from somewhere else. So if they're found in other places, the question really is, are they useful? And so they can be very useful if they're really, really elevated. There was a nice chart I saw. I couldn't find it anywhere after I saw it the first time. I was like, oh, I've seen this all the time. I'll definitely be able to put it back in. But I couldn't find it. If your AST and ALT are like greater than 1,000, you can kind of say maybe it's autoimmune, ischemic, or hepatitis. Whereas if it's less, it's more likely to be something else. And if it's really, really high, maybe it's acetaminophen toxicity. But the important thing to realize is that if the AST, ALT are above 200 or 300, that's when you start to get really high sensitivities and specificities for actual liver damage as opposed to somewhere else. And then the other thing to realize is that the peak values of the AST, ALT aren't really going to tell you much about the prognosis. They'll just kind of tell you, it can help you guide the etiology, but not necessarily the prognosis. Alk-phosphate, if you've seen elevation in alk-phosphate, just get a GGT to confirm that it's liver in origin if you're confused. And then bilirubin, it can have obstructive pattern in acute liver injury, and you tend to get more direct, whereas hemolysis and other forms will get indirect. Okay, and then coagulation factors. The liver synthesizes a bunch of factors. What's important about these is that even if they're normal at the beginning, there's going to be a trend in them, and it's important that we'll just trend them over time, or that they may even go up over the course of the emergency room visit, and that as they go up, that's going to be useful for prognostication and etiology as well. And then albumin is produced by the livers. It's a marker for synthetic activity. Its half-life is 20 days, so just keep in mind that it may be normal when somebody comes into the emergency room for liver failure, because it could be hanging around for a while. And then ammonia. I don't think it's the same ammonia as that, but I don't like that it's ammonia. And so this is elevated as a result of impaired clearance. And then there's a lot of controversy as to whether or not the level of ammonia in the body is going to correlate to encephalopathy. But something I came across as I was researching this is that the ammonia levels really should be done in an arterial sample, and the reason for that is because when they did the studies and they gave their levels that they can apply to hepatic encephalopathy, they were done on an arterial sample. So if possible, it's better to get an arterial sample when you're doing ammonia. And then just the basics, CBC, chemistry, looking for acid-base disorders, electrolytes. I mean, these people are at risk for thrombocytopenias, anemias, and just get a technical screen in case they're going to open up. And then the viral, hepatitis B, IgM antibodies, core IgM is what you're really looking for. But what's important to realize is that for hepatitis C, it's going to be RNA, and not looking for antibodies it's going to be sort of the RNA. And then imaging depends on what really the complaint is. All right, so now that we understand the labs, we can start talking about some real stuff. Okay? So let's talk about some prognosis, okay? So the first thing about prognosis is, or one of the big ones I'm sure we've all heard of, is the MELD score. It's the model of end-stage liver disease, and it was prospective, it was validated, and it was really used for TIPS, and to see whether or not it was used to prognosticate patients 3 months after receiving TIPS. It was developed in the Netherlands, and so, decent study, but the question is, it was used for TIPS, how can we apply it? What really goes into this MELD score? And so, what do we think would be good survival predictors, right? We think it would be like bilirubin, creatinine, INR, maybe the complications, whether or not someone comes in with variceal bleeds, ascites, or the etiology, if somebody comes in with hepatitis versus acetaminophen, maybe that'll help us determine the prognostication. But what they found was actually is that with the MELD score, the complications or the etiology really didn't have an effect on its predictability for post-TIPS procedure mortality. And so the thought process kind of changed a little bit. Maybe the MELD score isn't really a marker necessarily of prognosis, but rather a, once people have advanced liver disease and they're starting to get complications, whether it's variceal bleeding or ascites, maybe all those patients are at risk, increased risk of mortality, and that's why it doesn't really matter if they're MELD score, because it doesn't really matter if the etiology is a component, because they're already sick enough that it's not necessarily going to show a difference. So it was just something to keep in mind that when you see these patients with the chronic liver complications, these people are far along, so far that it may not even be necessarily this. Just a thought. Okay, and this is just what goes into the MELD score. So the MELD score is really your bilirubin, your INR, and your creatinine. And so the problem with this score is that patients may come in with elevated creatinine, so they may be on anticoagulation, so they may have high elevated INRs. And so the MELD score actually accommodates for this. You can only get a max creatinine of like 4, and INR I think of 2.8 or something like that. Don't quote me on that. But they apply these max values, and you would think that there is a bias to this. You would think that this wouldn't hold up, but it seems that despite all these additions they've made, it seems to hold up pretty well. But remember, this is just for TIPS procedures. So what are the applications of the MELD now that we know that it was used for TIPS really when it was studied? They studied alcohol hepatitis. It's useful for prognostication of alcohol hepatitis. They studied hepatorenal syndrome. It could be useful for hepatorenal syndrome. In acute liver failure, if you break it up by acetaminophen versus non-acetaminophen, in non-acetaminophen, it correlated with mortality, whereas in acetaminophen, it was no better than the King's College criteria or the INR itself as a marker for mortality. And then in variceal bleed, as you get higher, it's a marker for mortality. And just to show you the difference in scores between the MELD of 19 and 11, which I don't think is a very big difference, there's really a big mortality difference at that point. Okay, so again, the MELD is not perfect. They're working on modifications, and it's much more useful for chronic liver failure than acute. So the first type of thing that we'll talk about that applies to ED is Tylenol overdose. All right, so with acetaminophen toxicity, you really want to get a level. You want to correlate it with the timing. And keep in mind that when we talk about all these acetaminophen things, most of the studies have been done in acute toxicity. I actually don't know if I found any for acetaminophen that were really done for chronic, but I didn't really look that hard. I'm sure there are. All right, so one thing that I'm sure we're all familiar with, this is the Rumag Matthew nomogram. I meant to print out so I can read it to you while it's open, but I didn't get a chance last night. So anyway, so you have this treatment line. On the x-axis, you have the time post-ingestion. On the y-axis, you have the acetaminophen level. Of note that it starts at 4 hours. Okay, so if you get a person, they took the Tylenol, they come to the ED, you take a level right away, it may not apply because it may be too soon to get their actual level. Okay, so it starts at 4 hours, and if you look at the other end of the spectrum, it ends at 24 hours. So it's that acute phase, 4 to 24 hours. And it's really important to get the timing down because we're talking about a narrow window. And if you look at the difference, oh, it comes up, look at that. And then if you just look at, I don't know, I'll pick one right here. Where am I? I'm at 20. If you look at 20 at 12 hours versus 20 at 17 hours, it's going to be significant. You're going to treat. And as you get further and further away, like patients are like, you know, I think I took it at 2 o'clock or 6 o'clock. That can be a really big difference at 20 versus 24 hours. You know, that person with acetaminophen of 5 is going to get treated versus not 24 versus 20 hours. So it's important to keep in mind the difference and really keep track of that. And then there's not really, and then if they have extended release or if you're concerned at all and you should really trend it over time just to see that their Tylenol concentration is still going up if you're unsure about anything. And again, it can be used post 24 hours. So let's talk about the treatment for acetaminophen toxicity. Right? So the big one is N-acetylcysteine and activated charcoal. But activated charcoal hasn't really been shown to have that much benefit. And then the thing is, N-acetylcysteine, there are two doses you can give. You can give oral and you can give IV, and then N-acetylcysteine with activated charcoal, there's no decrease in absorption from the activated charcoal. So you don't have to worry PMS needs or something like that beforehand. And it has a controversial mechanism. Most believe that it's probably due to glutathione stores, but there aren't really many placebo-controlled or randomized trials when it comes to N-acetylcysteine. Yet we use it, right? It's kind of like the standard of care. And so the question is there really evidence if there's no randomized controlled trial? And so I just pulled up a whole bunch of trials that I found on N-acetylcysteine, and it looks like it goes back as early as the 70s. I didn't go through these trials, but it seems like it's, at this point, the standard of care because the trials were so overwhelmingly in favor of N-acetylcysteine as opposed to no treatment at all, or other standard treatments at the time. Okay, and so let's just talk about some indications for treatment. A 4-hour level above the treatment line. Single ingestion greater than 150 milligrams per kilogram with a max dose of 7.5. So if someone took 7.5 grams of Tylenol, you can treat no matter what. Don't wait for the 4-hour level. And then if they have an unknown ingestion time, and a level greater of 10 micrograms per ml. And then just if they have nothing crazy, a history of toxic ingestion without any liver injury. Okay, but don't forget, the most important thing, or not the most important thing, one of the important things is to call poison control. Because no matter what happens, it should probably be involved. And let's talk about the treatment algorithm. You have the 20-hour and the 72-hour. The 20-hour is typically used in the UK, whereas the 72-hour is used in the US for less than 30 hours. And there's a lot of different variations on this, but those are the standards. So we'll talk about the oral one, which is what we tend to use in the US. I'm sure there are going to be a lot of attendings at the end that are going to say they use either the 20-hour or they use the IV version of the 72-hour. Basically, you give a loading dose, and then it's followed by 70 milligrams per kilogram PO every 4 hours for a total of 17 doses. Whereas the 20-hour, which is really 21, you give an initial loading dose. That should be given over 15 to 60 minutes. Up to date recommends 60 minutes for that initial loading dose, and then various transfusions over the next couple of hours until you get to 20 hours. The problem with the 20 hours is that it often doesn't treat your entire toxicity, so you may need more at the end. Whereas the problem with the 70-hour or the 72-hour is that it doesn't necessarily overtreats. So it's finding a balance between the two.
Just a caveat that I learned on toxicology, I've heard that it's really disgusting. Like it smells like sulfur, and it's not really something that people are going to want to take. Just FYI.
Yeah. So the best thing, if you're going to do it orally, to overcome that, put in Coca-Cola. It actually masks the taste and the smell, not too bad. The IV, though, one of the things I want to emphasize that you did say is that even if you don't get a level, but you have that history of possibly taking it, and it's more than 24 hours, and you see there's liver damage, you still, just to emphasize, you kind of mentioned this, give it, treat it, and that way you only can treat IV. So if there's any evidence of liver damage, you treat it IV. And you carry out the 20-hour protocol. There is actually some nice studies from Britain in the old days looking at toxicity from acetylcysteine, where they had a lot of deaths in the early days. And in those studies, at least, not all of them were great, but anyone who got treated within 8 hours, there were no deaths. And in people, they did have deaths. Some of them were just case reports, but there were deaths in people who were not treated or treated late. So it's the standard of care, it works. Give it, and even if it's more than 24 hours, if there's any evidence of damage, give it and give it IV. And I've seen this, I've had several cases of this, where we reverse people who are already in fluid liver failure.
Yeah, absolutely. And then in terms of just the adverse events, as I mentioned, the vomiting, just to go over, I mean, if they vomit within 60 minutes of the oral dose, you want to give it again. If they vomit again, then you switch to IV. Another thing that can happen, and this is why you get poison control involved, because they can help you with this decision. So 10 to 20%, sorry, 10 to 20% can undergo an anaphylactoid reaction, which is not an IgE-mediated allergy, but it can present very similar to anaphylaxis. And so you're going to treat them the same way with the epi, the Benadryl, etc. But you actually are probably going to continue to treat them even after you deal with the anaphylactic reaction. And that's why it's probably one of the important reasons to get poison control on board early, because N-acetylcysteine at such high doses isn't always benign. And just to go IV versus PO, IV is preferred, as I mentioned, for any hepatic failure, vomiting, or any contraindication to oral administration. Okay, and then treatments, should we treat or should we transfer is the question you have to ask yourself as well whenever you get any type of liver failure. So this isn't just for acetaminophen now we're kind of branching out a little bit. And so again, we'll go over the stages of encephalopathy. Stage 1, mild confusion. Stage 2, a little bit of lethargy with asterixis. Stage 3, marked confusion. And stage 4 is coma. Okay? And then we have the King's College criteria. This was developed in England, I believe. And it has a whole bunch of things, INR, serum creatinine, ABG, and acidosis. Probably look it up, no need to memorize it now. But I did find this on Life in the Fasting, and I thought this was just a very good kind of like small criteria for it. Pretty much elevated INR above 3 or 4.5 at any time. They have elevated creatinine, acidosis, hypotension, hypoglycemia, thrombocytopenia, or any encephalopathy. Those are the patients you should really get transplant on board early and possibly get them to a liver center. And then what do you do for when they say no? Nobody wants to work. So for hepatic encephalopathy, you can treat with lactulose. It can cause diarrhea, get rid of the ammonia that way. It reduces encephalopathy, but has not been shown to reduce mortality. And then antibiotics is an interesting technique that I hadn't really read much about until prior to this, but pretty much the idea is to get rid of the ammonia-producing bacteria and kind of take off the production of the ammonia and the toxins. And you don't want to use neomycin because it can be nephrotoxic. And so in the acute liver failure, you don't want to take away their other organ clear. And then also rifaximin is generally not used just because there's not really a clear benefit. And then if they have seizures, you don't want to give benzos, you want to give phentoin or barbiturates because just decreased sedation. You don't want to, they already have encephalopathy, you don't want to knock them out a little bit as much. And then also, you don't need to prophylax them once they start getting hepatic encephalopathy in acute liver failure. And then how do you deal with the increased intracranial pressure that comes with all this, this fluid shift? So you can give mannitol to, which will actually increase survival. But what's interesting about the mannitol is that if they become volume overloaded with the mannitol, you're actually going to dialyze and infuse the mannitol at the same time. So it's kind of like that whole Lasix fluid thing. Like, do we ever do it? Usually not, but there are a couple of cases where you do. This is one of those types of situations. The other one is hyperventilation, decreasing the PCO2, trying to get vasoconstriction and reduction in intracranial pressure. This actually may have worsening consequences. It should decrease mortality, but it may worsen edema. And then barbiturates, they decrease ICP, but you run the risk of hypotension and decreased cerebral perfusion pressure. And then steroids. Steroids have limited research, so for now the verdict is not to use them. And then one thing we'll talk about is a little hypertonic saline. So the hypernatremia you can use to increase your intravascular space, but it takes the fluid away from fluid shift and to take it away from fluid going to the brain. And the studies are really for, this is where the encephalopathy grades come in. The studies are really done in grade 3 and grade 4 encephalopathy with high ammonia levels and acute renal failure, and are on the need for vasopressor support. And the idea is that you want to keep a goal of sodium of 140, serum sodium of 145 to 155. What happens if the patient gets a coagulopathy? You don't need to normalize the INR. If they're actively bleeding, go all out, give them everything you can to stop the bleeding, FFP, platelets. Asymptomatic patients treat if their platelets less than 10,000, and invasive procedures 50 to 70,000 you want to transfuse platelets. Okay, and is there anything else we can give N-acetylcysteine? Maybe it was studied in acute liver failure due to Tylenol. They studied it, I guess, because they can, right? So there are two major studies I found on it, like hassle for them a little bit. Muhammad et al., this was done in Pakistan, 47 patients, it was prospective, one center. They found 37.36 survived, 47% in the NAC group and 27% in the control group. And the control group was just receiving dextrose. And then the conclusion that they drew from that was that N-acetylcysteine should be used and it was safe. But the problems is that when you look at the patient population in that study, there were some major differences. One, in the mean age was a little bit different, the bilirubin levels were different. But I think, to me, what was most important was that you're dealing with a very big difference in terms of the etiology. I know there are a lot of studies I mentioned earlier, etiology probably doesn't necessarily affect prognostication, but in some types of etiologies, things that are sometimes passed on their own, it could really affect it. And there was also such a big difference, 17% versus 3%. But then a second study came out, 173 patients, 92 to placebo, 81 to N-acetylcysteine. This was prospective, randomized. They D5 or D5 N-acetylcysteine for 72 hours. And what they found was that the 3-week survival, not much of a difference. But the transplant-free survival, there was this very significant difference, 40% versus 27%. And then when they further broke that down, when you look at patients with encephalopathy of grade 1 and 2, not much, there was a big difference. But then when you look at patients with 3 or 4, not much of a difference. So those patients with early encephalopathy, it's really important. Maybe we should treat them. N-acetylcysteine is relatively harmless. Well, I mean, it comes with those nausea and vomiting, and it can come with the anaphylactic reactions, but patients typically do well for N-acetylcysteine, and so we should really have a low threshold for treating patients with N-acetylcysteine for any type of liver failure at this point. But there are always problems with every study. I thought there was really, a lot of them didn't complete the study, probably because a lot of them died, but also probably just because a lot of them didn't tolerate it well. And so just keep in mind that it wasn't really the best study, it wasn't a big patient population. And so what's the verdict on N-acetylcysteine? There really is no verdict, official verdict, but the general consensus is to give N-acetylcysteine and it needs more research. Okay, so let's just talk about other etiologies for a second. Mushroom poisoning, this is the hush-hush topic. I put it on there because I don't really know what the answer to the in-service question was. I still don't know at this point. There's some cases where you give dialysis, there's some cases where you give penicillin. I just thought it was important to put out there because I was talking to a bunch of people and I had never heard of the penicillin. I wish I prepared my lecture before the in-service because that's the answer I probably would have gone with. But it seems like penicillin could be a treatment for mushroom poisoning and transplant for mushroom poisoning as well. Viral hepatitis, you want an early referral to transplant center and you want to get early medications, and you'll recognize some of those names as being the HIV medications because they overlap a lot. Autoimmune hepatitis, prednisone is the big treatment, and you want to really get a liver biopsy to confirm autoimmune hepatitis, or just treat clinically as everything else is back negative. So just some chronic complications from liver failure, and so we deal with these all the time, and these are pulmonary edema, mucosa. Well, let's talk about ascites as being the first one. It's the most common major complication in cirrhosis. It's indications for parasitesis, abdominal pain, shortness of breath, and presumed compression on any vessels or abdominal organs. The complication rate is very, very low. And then one thing that always comes up is, do you do an INR before you do the parasitesis? Do you not? And at this point, I think the general consensus is that you don't need to do you don't need to check for an INR because it's not contraindication. But one thing that is important is performing a SAG. And what a SAG is the serum albumin ascites albumin gradient. This gives you a lot of indication as to what's really the cause. It's kind of like our Lights criteria for abdominal ascites. A patient really typically only needs it once in their life. So if they have a cause and they have a SAG, and it was already greater than 1.1, you probably don't need to repeat it, but it's something to keep in mind that if this is new onset ascites and you're going to tap it, then you should do it. And this is just to differentiate it, and pretty much what we're saying is that anything greater than 1.1 is things that are really due to the liver and supporting portal hypertension, whereas anything less than 1.1 tends to be things like TB, endometriosis, peritoneal stuff, things outside of the liver that are causing this. All right, and so how much fluid do we take off? So I know we throw around the term large volume paracentesis. Typically, a large volume paracentesis is defined as any paracentesis greater than 5 liters. And it should only really be, it should be used in patients who are diuretic resistant. So patients who require large paracentesis, but they're still getting diuretics, and that's still a very useful way to get their fluid off, you probably don't need to take off that much fluid with the paracentesis. You could probably take off a few liters and then bridge them over to some more Lasix or some other medication. And then, do you give albumin or not? So it's a little controversial. I tried to make the monitor here, looking like it was at the belly. Anyway, albumin. Whether to give it or not. 2 big studies, one in 1988 and one in 1997, so you can see there's still a lot more to be done on this. One had 105 patients with tensicytes, the other one only had 12 patients. The one with 105 patients in 1988 showed that giving albumin, that patients who received albumin had less complications, they had less hemodynamic instability, they had better renal function, they had less hyponatremia. And those in the other study in 1997 with only 12 patients showed that there was really no difference in 48 hours. They used markers like central blood volume. I tried looking that up. It seems like you inject something that measured it at another site and see the difference. I don't know if it's a good marker. It wasn't, I couldn't really find much information. But in any event, they didn't necessarily use good measurements, good dependent variables, and it was only 12 patients. But that one showed that in patients, the first one, the limitation was that they found that most of those patients that received ALP, that in the differences, they found the difference to be in patients who were not secluded because they were diuretic resistant, and in the 12 patients, that those patients were all biopsy proven and diuretic resistant. So therefore, it was more applicable to the standard ascites with large volume paracentesis, and in those patients, there was no hemodynamic instability. So they actually found it to be okay to use, to not use ascites, again, for diuretic resistant. So then what dose of albumin do you give? You can give the 25% solution or the 5% solution. The 5% solution carries much more sodium, and so it should be used in dehydrated patients, whereas the 25% is used for the hypovolemic patient. But both solutions are essentially isotonic. And how much and how fast? The optimal dose that hasn't really been studied. I don't think that was the right word. I think I meant optimal. But so what about? There wasn't really any head-to-head studies. So the study was done at 48 grams per liter. So now they compromise and they say 6 to 8 grams per liter. But again, there's no research for this. You have CGI recommending a lot of different variations. And I asked the fellows numerous times after they told me to do it, and they don't even know which albumin they want to give, 5%, 25%. So if you want to give it, just I think give what you want. I don't think there's really much evidence for or against. And then another complication is SBP, spontaneous bacterial peritonitis, and it's infection of ascitic fluid. And then it's defined as PMNs greater than 250 for positive fluid culture. And what's important here is that you have a bunch of different, you have Klebsiella, you have E. coli, you have Strep pneumo as your common cause. But if you look, they found that in all patients, asymptomatic, in outpatients, they were 3% of them ended up having positive, they had, with asymptomatic patients that were just doing CAPs, they did cell counts on them, they found to have SBP, whereas 21% of patients as inpatient had SBP. And so the recommendation is probably to send cell counts for all fluid removed. I'm not sure how strong their recommendation is. I know a lot of us don't do that here, and there was a lot of controversy in what I was reading about whether or not to do it. But one thing that probably should be sent, if you're suspecting peritonitis, certainly send all those labs, the glucose LDH, CEA, alpha and total protein. But what they did find was that if you're gonna send it in, you're gonna send the PMNs, you should probably send the culture as well. Because if you're suspecting anyone with a fever, abdominal pain, or leukocytosis, you should treat them regardless of their PMNs. You should treat them until they're culture negative. And you should give them antibiotics, cefotaxime 2 grams, IVQ8, or amphotericin or aflatoxin. And now let's move on to
just something to add to that. I had a patient with a malignant ascites, and I thought that they had SBP, and I looked this up. If your SAD is less than 1.1, your chance of getting SBP is significantly reduced. The patient goes to get SBP in the obstructive pathologies.
I think Dr. Sidhu always says is that patients with malignancy don't get SBP. I think that's like his thing. I don't think he ever taps anyone for SBP. I've heard him say that.
Yeah, so you can use the triglycerides in the
is the most common fatal complication of chronic liver disease. It's upper GI bleed in the patient with cirrhosis. And there was an article going around from Dr. Sinner. I wish I knew about this before I prepared my thing. I think it was more from lower GI bleed. But you can use it to confirm bleeding if you're unsure whether or not the person's having an upper GI bleed or not. Okay. And so what you want to do, large bore IVs, fluids and blood, and then medical therapy. And so we'll focus a little bit on medical therapy. So octreotide, vasopressin, IV nitroglycerin are the mainstays of therapy. And so the question is, what they really do is you have this increase in portal pressure, and you're going to use vasoconstriction to decrease inflow, and nitroglycerin to hopefully locally vasodilate, and octreotide to also decrease portal hypertension. And so hopefully you'll be able to reduce the pressure in the varices and stop the bleeding. But it's an unclear benefit as to whether or not these medications help. They do show that they have a less failure in hemostasis, and they also decrease the number of blood transfusions. But I think it was the 30 and 120-day mortalities that were studied that there was no difference in patients who had medical therapy over not. And then I looked, and then there were a bunch of Cochrane reviews on this topic, and one of them is on endoscopic sclerotherapy. I don't know exactly what GI uses. There's band ligation. There's a lot of different methodologies that they can use to get rid of the varices. But one of them is endoscopic sclerotherapy. And with endoscopic sclerotherapy, what they do is they go in with an endoscopy, and they'll see the vessel, and they'll inject things into the vessel and hopefully sclerose the vessel. It's typically used for when rubber band doesn't work, but now it's becoming the main their go-to for first, because they're like, rubber band doesn't always work. Why bother just go through that? What they found was that when they studied sclerotherapy versus medications, there wasn't really a difference. And the only thing that was really different was that there was an increase in adverse events in patients who got the endoscopy. So again, I mean, the standard is medications, GI for scope. But I think in the future we'll probably see a point where that may not be the standard of care, because there's a lot more research coming out saying that this stuff may not be better. And then as for prophylaxis, band ligation versus beta blocker, just to decrease the flow with the beta blocker versus band ligation. Again, not much difference. And beta blockers are actually a useful method of primary prophylaxis. But they determined more data was needed. And antibiotics for patients with variceal bleeding, a lot of them are at risk for severe infections, which is very common in cirrhotics, and so we should start them on IV antibiotics in the ED before they go to the GI suite or maybe wherever they're going to go. And then let's talk about Budd-Chiari syndrome for a second. Sorry, how much time I have? Perfect. Budd-Chiari syndrome. So Budd-Chiari syndrome is essentially kind of like a DVT of the hepatic vasculature. It's an obstruction of the hepatic vein, the hepatic venous outflow. And so what happens is it can either be from thrombotic or non-thrombotic, and you get this blockage in the hepatic vein, and you get a buildup and a back up and a lot of pressure, and this can cause hepatomegaly, ascites, and abdominal pain. And it's something that I think gets overlooked a lot, but it's important to keep an eye out for because its mortality is incredibly high. The 3-year mortality is almost 100% for patients 3 years after they get diagnosed with Budd-Chiari syndrome. Signs and symptoms are not that uncommon for what we see in the ED for someone with liver failure, whether it be acute or chronic. Jaundice, ascites, hepatomegaly, splenomegaly, right, the things you always see, ankle edema, not uncommon, stasis ulcerations, and prominence of collateral veins. So it's something that's walking through our doors very, very frequently, and I don't, maybe we should pay a little bit more mind to it, and to keep our eyes open, because there are a bunch of different forms. There's the acute and the subacute form. And in the acute form, in the subacute form, you're going to get a rapid development of these symptoms, a rapid development, and the big thing is here, you're going to get abdominal pain. And so it's an acute clot, and so you treat it as such, and you'll anticoagulate, but what tips you off to acute is the pain. The problem is that most patients with Budd-Chiari syndrome present with the chronic presentation, and they get ascites, they may not even get jaundice, and approximately 50% have renal impairment. possibly due to preload, possibly due to a development of renal syndrome. And that's the most chronic presentation, and that could be non-tender, the liver. And then fulminant is also very uncommon, and that's also tender because it's just complete failure of the liver. And so you diagnose it with the ascites, and so patients with high protein on their ascites, greater than 2 grams, it's typically going to be what you see in people with Budd-Chiari syndrome. And they also have a low white count, so you're not going to be thinking about SDP. And then they're also going to have a less than 1 for their SAG. And then for imaging studies, you can do ultrasound, CT, MRI. The idea is just find the clot. It's something that GI, I think, does more as outpatient, but just something to keep in mind because those patients do very well with liver transplant, or do not necessarily very well. Patients with liver failure tend to die, but it's something that if we get it early enough, we may actually be able to help them. And then just treatment is really correcting the predisposing disorders. It's getting them on anticoagulation early. You want to treat the portal hypertension, and then they may require angioplasty or stenting, or even TIPS. This is where TIPS really comes in handy, IR-guided procedure, and then eventually getting them to the liver transplant center. And so that really concludes my talk on liver failure, but including chronic. I just want to say thank you, Hassel, thank you, Dr. Regan. Any questions? A single clap.
Yeah, I have a question.
Yes.
I'll clap real loud. Can you do a transplant after you've had like failed TIPS? If someone's like encephalopathic after TIPS, can you still send them for transplant?
I think so. I think that's one of the indications for transplant.
Yes, you can.
Yeah.
Actually, it'll increase your score.
Yeah, I was gonna say.
Your chances of getting a transplant.
So yeah, it used to be they prioritized based on first come, first serve. But now, in the last couple of years, they changed the transplant formula. So the sickest patients actually get it first.
Someone has a really high MELD score, that's a patient we should transfer, right?
Yes.
Right out of the ED.
Yeah. Where is it? I don't remember where I put it, but it's in here somewhere with the King's College, sorry. Anybody else questions? Yes?
So just because you mentioned it, so with mushrooms, since there was a board question on mushrooms, the thing to remember, general rule, not always true, that if you have acute vomiting with mushrooms, if you vomit like almost right away within the first couple of hours, they're usually benign, right? They're usually just GI toxic and that's it. The very dangerous mushrooms, like Amanita phalloides and some of the others, usually, not always, but usually the vomiting is later, like after 4 hours. So if you get delayed vomiting, you got to worry that this was a very, very toxic mushroom. That was kind of the question.